Hello, and welcome to today's health webinar. This episode is brought to you by our friends at the American Heart Association. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Dr. Donald Lloyd-Jones.
Well, thank you so much, and thank you all for joining us today for this AHA and Health webinar entitled Shaping the Future of Global Heart Health, the Role of Payers and Providers in Advancing Access, Innovation, and Prevention. I am so pleased to be with you all today, and I'm particularly pleased to be joined by a really distinguished panel of experts who will be discussing some of the, I think, exciting aspects of the technology and the ways that we can engage patients, not just here in the United States, but really around the globe, to making sure that we really are improving access, innovating ways to meet those people where they are, and of course, improving prevention, one of the things that I'm most passionate about. My name is Don Lloyd-Jones. I'm a cardiologist and cardiovascular epidemiologist. I'm the principal investigator of the Framingham Heart Study here at Boston University School of Medicine, and a former president of the American Heart Association. I'm going to do a very quick round of introductions of our panelists, but then later on, I'll ask them each to give us a little bit more information about their journey and where their expertise comes from. But just briefly, so pleased to be joined by Jeff Bennett. Jeff is the former CEO of Higi. I think we're all familiar with Higi and have seen their carousels in various locations where you can do things like measure your blood pressure and your weight and get feedback about your health status. He's currently the Chief Strategy and Innovation Officer at Motive Care. And so we'll look forward, Jeff, to hearing from you a little bit more. Also joined by Dr. Ritu Thaman, who is an associate professor at the University of Pittsburgh and a cardiologist and a real leader and thought leader in prevention efforts and also engaging payers to improve access to care. Ritu also a very prominent, I would say, social media expert and really spreading the good word about cardiovascular care and prevention. And finally, Dr. D.P. Suresh, who is a cardiologist and really eminent international expert in improving systems of care, and based at St. Elizabeth's Heart and Vascular Institute in the Cincinnati and Northern Kentucky area. D.P., great to have you join us today as well. And thank you all for being here. So with that, I will maybe turn to each of our panelists to kind of give us their initial perspectives. I want to reiterate, please use the Q&A function so that if you have questions to address generally or to any one of the panelists, we can certainly get to those. So we'll hear from each of the panelists for a few minutes. We'll have a little bit of back and forth Q&A, but then want to open it up after about 20 to 30 minutes to a more general Q&A across the board and engaging all of our panelists. So Jeff, maybe I'll turn to you first and again ask you to give a slightly deeper dive on your journey and how you got here into this area. And what are the things you're seeing in innovation, which, you know, it's been exciting to learn about what you're doing to really bring care to where people are and, you know, including things like improving transportation so that they actually have access to things, but bringing the technology right to the patient where they're likely to encounter it to improve their healthcare. So would love to hear a little bit more about that.
Yeah, Don, thank you for having me. Love to share that a little bit. Maybe I'll start off maybe a little bit on a personal journey of kind of where I got here in this whole process. Some people have heard the story, and those that haven't, I think it's an important piece of my pathway and what drives our mission. I think for the broader organization, because a lot of people that work with us are doing this, are dealing with things like this. So I grew up in a family that was affected by heart disease. When I was 11, my dad came home and was having a heart attack, actually, when he was 41 years old. Fortunately, because of great cardiologists and doctors, his life was saved. He actually ended up having several heart attacks that night, actually 2 or 3, I think, and several more over his lifetime. Had 4 open heart surgery, 12 angioplasties, 2 carotid artery surgeries. I mean, just basically used the healthcare system like no other, I think, in some ways, and lived for 30 years. So I was grateful for everything that the science basically supported along his journey. Unfortunately, 9 days after my dad had his first heart attack, my uncle at 38 died of a massive heart attack. So it kind of shows the difference between just, you know, one child who had a father, even though he had health conditions. I had him for 30 years, my cousins didn't. And then, you know, I've lived with heart disease now as well. So at 35, even though I was qualifying for the Boston Marathon, running 7-minute miles and marathons. I got diagnosed with heart disease with a left ventricular descending that was 50-60% blocked, maybe more, depending on how you looked at the imaging. But knock on wood, my goal is to avoid that. And a lot of that is around prevention, and a lot of things that, I know the HA science drives and the Life Essential 8 drives. So I live that every day, not only what I do personally, but also what we do from a business. So I'll jump into the business side now, because on the business side, started my journey on this with Higgy. So we wrote the plan and was joined as CEO back in 2013. And really, the main goal of Higgy when we started was how do we bring access and take care of members and patients in settings where the traditional healthcare system isn't there to support them. I mean, so where if you're not in the hospital, if you're not in the doctor's office, how are we going to identify what issues you have? And so many people in this country don't have access to primary care, don't have access to preventative care. So our Higgy platform was designed to really provide access to people to understand their numbers, to learn about what things they can do with their numbers to change their behavior. So we've created a program called the Heart Health Guide with collaboration with the American Heart Association that brings all the Life Essential 8 content. So allows you to take the journey of, do you want to change your smoking? If you smoke, if you want to stop doing that, do you want to exercise more? Do you want to work on medication adherence? So we basically give you content from AHA Science to help you navigate, and over 300,000 people have joined that program, just as an example, to see that journey through that. Of the 400 million blood pressure tests that we've offered, over 400 million blood pressure on these stations over the last 12 years. So that's the first piece of this is finding a location that has trust, that has a relationship in the community with individuals, that gets people to sit down. And we found pharmacies, but also, WIC centers, community centers, libraries. These are all really good locations because there are food deserts, there are RX deserts, so there isn't going to be a pharmacy in every location. So a big part of that was just driving that access through trusted organizations. We very much believe in everything we do at Motive Care around monitoring that relationships matter. And the relationships that we really leveraged in the first part of Higgy was really the relationship with that pharmacist or that community-based organization. As we worked through this, several people came to us and said, wouldn't it be great if you could actually talk to a doctor as well? So now we've launched a telehealth enabled station. And first we did this with support of the American Heart Association with University of Rochester Medical Center. Is now, how do you bring mobility so you can actually talk to a doctor right there, so that you could understand maybe some next steps of what you could do. So immediate care, urgent care, in the future, maybe in primary care. And we have now not only did it with UMC and had that successful sort of test of, can we actually get a virtual visit there on the stations, all self-service, no person there except for the individual. And we're now launching this with 2 large MCOs, one in urban underserved neighborhoods of Chicago, and the other one in a very rural part of Nevada where there really is limited access to care. So really bringing this access out. And as we're doing this, it's not just about the clinical care, it's about understanding your S2H, health-related social needs, because those are the first things we need to address before that. And then after that, we can identify other things that we can address over time. So we're now rolling that program out with those 2 MCOs to kind of pilot sort of rural and underserved access. And with this as well, we're we're collaborating with the American Heart Association and doing something with AHA sessions in the community in Louisiana, in the New Orleans area. So that's launching with AHA sessions. That's coming up here this weekend. So that's the first part of what Motive Care monitoring does. We also have around this, when you have greater needs, we can now engage you at home. So we provide a PERS device for those that are socially isolated, have risk of fall, and we don't just call 911 or your family caregiver. We actually build a gap closure program. So 95% of the buttons that push are not around a fall or a 911 call. It's really about kind of loneliness or just the ability to want to connect or test their button. So we actually suggest all the gaps that can be closed for those members. So with that data, we identify, a large portion of those members have unmet needs. So we identify risk factors, and then we close those gaps by educating them how they can close those gaps. And we see in the data with our plans how they can lower the cost of of care because we avoid ED, avoid hospitalizations from that, and we see really good outcomes. So that's part of it around addressing, I guess, falls in social isolation, kind of an S2H issue around that. And then we also have a clinical network that does what we'll call risk appropriate home monitoring, chronic condition management, and gap closure. So we partner with MCOs or with risk-based providers. And we're really an extension of their care team where we'll build a care plan, manage that care plan, provide a dedicated nurse at the highest level, and then walk them down to just 24/7 monitoring and engagement, and then to digital-only monitoring to really do it cost appropriate because plans and providers have limited dollars. So we can't spread care like peanut butter. We have to get them in the right care program. So it really complements the community monitoring. If community monitoring isn't sufficient, then we can go in the home. And then at the home, we can actually do that risk appropriately. So this is all kind of on the foundation of being an extension of payers and providers in the home. And the other complementary services we can add on within Motive Care, which is in the family of companies that we own, is personal care services. If you need support for ADLs, we can do, bathing and meal preparation, some, daily sort of house needs around that, taking care of the member there, and then transportation. So we provide risk appropriate, in some ways, I'd say, transportation. So we can do mileage reimbursement to an Uber, to a Lyft, to a wheelchair accessible van, all the way up to an ambulance. So we get you into the right type of transportation. And within that, we have programs in rural populations as well that allow for us to do workforce management. We can always train people that can get jobs to actually take people in rural communities where you need it. So that's the suite of capabilities we do at Motive Care. I have the chief strategy officer title, so I gave you the full thing, but I also lead the monitoring division because of my background and history and passion around that.
Jeff, that's just incredible. Thank you for walking us through that. And I think, it's exciting to think about all the aspects of the ways that you're touching, patients in different ways and truly meeting them where they are. I mean, that for me is really exciting. Maybe just a quick clarification of one thing you said, and then a couple of questions. First, the clarification, which is you mentioned Life's Essential 8, and many of the folks attending the webinar today may not know what that is. So perhaps I'll take moderator's prerogative and just point out that this is an AHA platform. It is really it's a means for which people can measure, monitor their health over time, and modify it to improve their cardiovascular health. So Life's Essential 8 are 8 metrics that can tell you about your cardiovascular health status today, and also kind of give you a sense of what you need to work on to really maximize or optimize cardiovascular health. And the 8 metrics of Life's Essential 8 include, not surprisingly, healthy diet, physical activity, avoiding nicotine exposure, and healthy sleep. And then the things we tend to measure in more clinical encounters: our weight, our blood pressure, our blood sugar, and our blood lipids. And so, optimizing any of those 8 things can actually help improve our cardiovascular health status today, but also improve our long-term outcomes. So love that you're engaged with that. It's something that obviously I'm passionate about, wearing it on my sleeve. But to drive to some of the really wonderful comments you made, I think you said the word trust a couple times, right? And I think it's such an important part of our environment today that, we've lost trust. We've lost trust in science. We've lost trust in healthcare. Doctors used to be the most trusted individuals in people's lives. I love the way you're making these connections, but how do we restore that trust? What are the kinds of things that through better access, through innovative technologies, how does that bring people closer together and bring them closer to the healthcare that they need?
Yeah, I think I use almost our PERS business as a really good example of this, and even I'll jump back over it even to the community-based stuff we do. One thing is putting yourself in the shoes of the member or the patient or the consumer, again, whatever term you want to use in the whole process. We don't ask any questions if we don't have a good answer of how we're going to help them address it. So a lot of times in this process, it feels like it's a one-way street. Like there's a lot of questions asked and all the documentation happens and nothing gets returned back in this. So much of it, this has to be a two-way street. My wife is a doctor as well. She's an OB/GYN, and there's also the side of it. So, well, Dr. Google came in and told me what I should do, and I'm not going to listen to you. That's not what I'm kind of going down the path of. But if we're going to ask, make sure you give someone back and make sure they understand why. we're asking this. So as we go through and we ask the questions on sleep, but like we're explaining to them why we're asking questions on sleep, why we're asking questions on nicotine usage or other things. So I think it's really important to educate, because literacy isn't always there. I mentioned Life Essential 8, just assuming because I saw it, like everyone knows it because it's on your on your sleeve. But no, I mean that doesn't mean that everyone should know it. So how do we make sure we stay with them and speak on their levels? I think the other piece of this is you know, practicing at the top of your license. So we have an amazing care team on the PERS side that, are providing service. I mean, they're not highly paid doctors, right? But they're listening to the member and listening to their needs, and we're gathering so many insights off this, and we don't have a time limit on that conversation. And so the benefit of, because we're letting people practice the top of the license, is we can use that to gather that information, and then we give them very good personalized information of how they can actually take advantage of the benefits that are there in a trusted setting. Because I tell my in-laws, do not trust a text, do not trust an email. So trust is something that we actually tell them not to do. So when we have these trusted moments, like when they press that PERS button, or when we're talking to them once a month through our home monitoring program, or when they're at the station that's there because the community-based organization told you to use it. So it's trusted because of that. It's trusted because it has the AHA logo on it, right? These are things that we have to leverage in this. We're taking those moments to give them information, and we don't sacrifice what I'll say self motivation, like, oh, I need to get these gaps closed and all these things. Like, let's make sure we actually give them something back in return. So that's how we get, I mean, on the PERS side, we have an 85, 86, 87 NPS score, because we put the member first, and then the member comes back when they need more
Yeah.
things. So I think it's really important to get give and take. So that's a big part of this. And the other piece of it is we don't operate as a silo to the health system. So when there's an escalation, we write an escalation report that goes back to their doctor, back to their case manager, back to their care manager on the plan. Because if you operate these businesses in a silo, then you're not helping anybody, because now the doctor's going to be telling them something different than what you're telling them. And you really need to coordinate and make that, because otherwise the trust gets lost because the two people aren't saying the same thing. And that really quickly you lose and break down. Well, am I going to trust you guys, or I'm going to trust my doctor, or I trust neither one of you, because you guys don't know how to even talk to each other. So those are things that how we bring trust and relationship-based care, and really don't try to compete with the health system or the provider, but really complement them, because they can't be in the home 24/7 watching things. It's not viable. So that's the things that or in the community screening 400 million people, right, across that's not viable in that whole process. So those are things that we do.
Well, I love that, bringing the human connection to, on top of the technology, because the technology will only go so far in creating that connection. So I think that's just incredibly important. More questions for you, but I'm going to pivot now and bring in Ritu. Ritu, so wonderful to see you, as always. You've thought a lot about solutions that can tackle some of these really important conditions, very prevalent conditions like hypertension, like valvular heart disease, things that payers, of course, are going to be interested in investing in, right? So how can we kind of shift the paradigm towards prevention? A little bit of investment upstream can save a lot of money downstream. So I'd love to hear your thoughts and where your thinking is about these things right now.
Sure. Thanks so much for having me. So hypertension, as you obviously know, is a huge problem in this country, and one that we have not successfully managed. And we're continuously trying to, and with the new AHA guidelines, really upping our focus on this condition. I got started in prevention and hypertension when we started a postpartum hypertension telehealth clinic, and that was in 2018 here. And now it's served over 25,000 patients. And we have good data to show that it not only improves mortality, it lowers costs because you have lower hospitalizations. It was a key part of getting that covered by Medicaid, getting it expanded for these women. But now, really, I can see from the payer's point of view, we need to have everything aligned. Whatever I am seeing from the payer side and the patient side has to be aligned incentives. How do we get there with hypertension, for example? It's such a huge cost. And one of the ways is that the government has a program, the HEDIS stars. And so if health centers have their hypertensive patients controlled, they get extra dollars for that. And each HEDIS star could be worth up to, several millions, up to, even more than that, up to 50 million, depending on the situation and the type of center we're talking about. And I can say here at UPMC, it's a huge problem. Now, hypertension, because it is such a huge problem, has triple the amount of scoring. And so it's a problem that where the incentives are aligned. And so one could make a business case to say, why don't you use RPM? And we have been using RPM. We're trying now to modify it and actually improve it. We just got a $2 million grant to really focus in on implementing hypertension control in our population, over 100 clinics. Now, the question there is, well, how do you do that without innovation? You need it at scale. You can't just be giving blood pressure cuffs for 25,000 people and then expecting them, we have to keep up with those measurements. There has to be technology innovation involved. So that's a place where we're in discussions with different companies to see how can that innovative piece come in. Can we use PPG? If we use PPG, how are we going to use it? That's photoplasmography for those that don't know that PPG abbreviation. And so we're in the process of trying to figure that out. Do you use a waveform? Do you use how is that correlating with your blood pressure? Because that's something that's low-hanging fruit, right? Everyone could potentially get a watch or a band that just has that signal that is all based on light, and it's pretty cheap to manufacture, so we don't have to spend too much upfront on the cost. Now, the wrench in all of this is, as you probably have heard, that United, which is the biggest insurer in America, $400 billion company, just announced that they are not going to be sponsoring RPM as of January 1st, only for postpartum hypertension and chronic one other area. And that, is a lot of people are going to lose coverage for things like hypertension. And it'll be interesting to see how that plays out. Now, on the other hand, the current administration has also put out a $50 billion grant, obviously smaller than United, but it's for rural healthcare. And that's where telemedicine, telehealth, that's where it began, because we argued for decades that, we need it in the rural population. Now the changes have fallen back to that time period where we were just using it for rural health. And now we're right back to that. So all those things that we used during COVID time all have expired, those waivers. So we don't know how what the outcomes will be, but we certainly do know that, for example, like with this PROCORI grant that we have to study how do we implement hypertension control. And that's a small segment, that's 25,000 patients, but obviously it can be done. It was studied at Duke and published in just July, where they did show that it was feasible, and it was using PPG technology and blood pressure cuffs in combination. So there is that huge potential here, but it has to start with the alignment of what the government is willing to pay and with what the patients really need. And my desire for access and disparities is the main reason I went to medical school. It's been sort of the force, the passion in me that has led me to start the Pennsylvania Women in Cardiology group, to head the disparities of care for the ACC, for my work now with the AHA, which is really trying to connect both these sides, the business side, the science, but really being the patient advocate, knowing both those sides, to bring it forth and to say, we have to do this. This is why AHA is involved. We're a relentless force for improving and extending and lives, living healthier. And so this is really a fundamental part of it. I'll stop there, but I'll take any other questions.
No, really wonderful discussion. Thank you so much. And maybe again, I'll just kind of do one question. I was gonna ask Jeff this, and you went right there, so I'm gonna ask you, and then maybe pull Jeff in as well. But you mentioned this. Telehealth was everything in COVID, and it's of course pulled back substantially now to a fairly limited usage. Obviously, we need to get back there. How do you see its best use these days? And what do we as a community need to do to get back to using it more effectively to touch patients who otherwise can't come into the office? So I'd love your perspectives. And Jeff, maybe I'll ask you to comment as well.
Yeah, I think that it's going to have to come from within the healthcare centers, along with companies such as what Jeff has been doing in combination, because I don't think one size fits all is going to work. And the government has really pretty much said that, and they're giving us other tools. And we have to use these other tools to get paid. So we have to say, let's align our strategy, internal strategy, so we can get the extra HEDIS stars. If we get the extra HEDIS stars, then that's going to cover the payment. So even if RPM goes away, which it has right now, we'll get it back because we're going to make it up in the HEDIS payment if we improve hypertension control. And they really want to see that. So it is a win-win for both sides. So I think we have to think in this framework, never to give up. I mean, all of us are in this field, never to give up, but to say, okay, well, if one door is shut, if the government's saying we're not paying for RPM, but on the other hand, we are paying for these HEDIS stars, then we're going to use those to pay for the RPM. I mean, it seems like that's the way to go.
Yeah, so obviously the payment model and the viability are crucial. And so finding those other pathways, as you say, that health systems can use to cover the way that they're engaging patients is critically important. Jeff, your thoughts on this issue?
Yeah, so we run programs that kind of look very similar to RPM and kind of a CCM, and then gap closures on top of them. We do it for patients living with diabetes, with hypertension, preeclampsia, gestational diabetes. We cover both, older Medicaid members that have chronic conditions, and then the expecting mothers. The Medicaid rules and how we're dealing with it right now is, fortunately, we're able to continue a lot of those programs because of the types of populations that we are servicing. But I think the key on this is, I think a lot of it is RPM and CCM. I believe it should continue, and I don't agree with maybe what the United Healthcare did on this whole pathway. But I think there is a long-term evolution that RPM alone isn't enough. It's kind of like, how do you go down the path of, when you're doing this, to take care of other things, including gap closure and other things. And when we start moving down the pathway of showing that you are actually lowering the total cost of care and you are improving the quality measures, and that's where it's just hard to kind of calculate that payment model. But just collecting a blood pressure and not doing anything with it isn't sufficient either, right? So there's some businesses that were taking advantage of it, just like collecting a pulse reading and saying, oh, we're monitoring a physiological measurement. That's not doing us any good in this market either. So I think there was the far side that doesn't provide any value whatsoever, that was maybe business model driven and not outcomes driven. And I think the center was like, okay, let's test and prove this out. And I think we're still in that testing phase of like what you're talking about right now through PMC, like how do we build this in a more scalable way, maybe using PPG to get some risk stratification or some sort of identification rising risk, and then you use maybe community-based programs, whether it's a kiosk or it's even someone coming in and doing hypertension clinics to kind of screen people. And then you have obviously people that are living with preeclampsia. You're not going to ask them to, go someplace like they need to do it twice a day down this whole pathway, so or more, right? So you were going to have home monitoring in there. I think that's what we need to drive towards, and that's what businesses need to be pushed in the direction of. And I think United's just has jumped a little too fast, in my opinion, to cut off this. And they're still covering it, like you said, for preeclampsia, for women that are expecting, for congestive heart failure. And I mean, to me, I think that's where things need to move, because you should not only just be monitoring, but providing care managed, but maybe titrating medications and ordering labs and other things. Like that's where really we should be moving down the path of us. How do we really be that extension of primary care to do what you would do if you were in the doctor's office every day, which you don't want the patient there. You only want the patient back there when it's not working or they need to have their annual visit or however often you want to go do. And that's where I think we should evolve the market over time. And, the telehealth thing is unfortunate. I think there's no question that telehealth is a valuable service, not only for providers, but for patients, and provides access there. And that's stuff that we should need to bring back.
Yeah. And I'll just pile on to say, I think we shouldn't only be talking about or thinking about the physician being the key part of this kind of interaction with patients through telehealth and other means. Of course, team-based care, more and more is going to be important as, we have overburdened clinicians. And we actually have great algorithms for care for things like hypertension that can be managed more effectively, not just effectively, but more effectively by pharmacists, by nurse practitioners, by other healthcare professionals, and kind of save the time of the physicians for the things where you need in-person diagnostics and things like that. So I think team-based care is an important part of this conversation, and again, the compensation model has to be worked out for that. No doubt about it. Maybe
Yeah,
go ahead, Ritu. Yeah.
Sorry,
one
okay,
thing about innovation in this space, because I think that's where AHA is really playing a critical part. We're in talks with different companies that are actually utilizing the PPG technology, but are really at the cutting edge, like the bleeding edge. For example, there's a company that will just take your finger on the camera and measure your PPG over a minute, and that'll give you a reading. There's another one that just will measure just conventionally PPG, and then it will give you an idea if you're actually at level 1 hypertension, or you're level 2, or really high, like level 3. Because what we need is, well, what am I going to do with this number? Like, is it that, do I need to escalate the medicine? Do I need to start a medicine? Do I need them to, be monitored more carefully? So I think that's really where the innovation piece comes in, and where, us connecting that. And it's very exciting, because if you just had a PPG reading, then you can just have an AI algorithm, get the human out of the loop, and then, have them direct the care. So that's hopefully a model soon to come.
Great. DP, I want to bring you in. You've been very patient. Thank you so much. Great to see you, my friend.
Yes.
You've been such a huge leader in, these are not U.S. problems solely, right? Access is a problem globally, and you've been such a huge leader for AHA and in many other venues in international access to care, prevention being a particular focus. But you also, I think, importantly, focus on the quality of the care that's delivered, not just the access, but the quality of that care in international settings. And I'd love you to talk a little bit about the kinds of quality programs in heart disease and stroke that you're helping AHA to implement globally, and anything else you want to talk about. It's always a joy to hear you talk about your ideas.
Great, great. Thanks, Don. Thanks, Ritu and Jeff. First, it's a great honor to be with both of you. You guys are pioneers in the field, and I've taken what the AHA has taught over the years. And just to go back, I'm a cardiologist, trained in both interventional and heart failure, and I'm an executive director at the Heart Institute in Greater Cincinnati, Northern Kentucky. Just a few lines about what we are doing in Kentucky, being one of the states that, if you look at health parameters, we are probably 47 out of 50. So access is really huge in this part of the world. So, I've helped create a same day, next day follow up in our Heart and Vascular Institute with our physicians and our nurse practitioners. And that's something that's entwined into our care model. We have a large program for prevention, and we are one of the centers in the CKMH um, initiative that the AHA is doing, and also a hypertension pilot that we're a large health system, 5 hospital system in all over Kentucky till Lexington. So it's a big problem that Ritu was talking about that we are trying to address. Be that aside, now going on to taking this to the next level. So I'll just start off with the story. So about 6 weeks ago, I was in the country of Indonesia. Indonesia has 250 million people and 1,900 cardiologists. Let me say this: 250 million people and 1,900 cardiologists and 5 heart failure physicians, 5 heart failure trained physicians. So think of the gravity of the situation that the AHA is involved in. So now we are in the process of starting a pilot in 4 health systems in Indonesia with 4 heart failure physicians to start heart failure systems of care. How do we do that? What's the gravity of it? That's where we are talking about. Meaning there's no book to do this. We're going to start with them. We're going to figure out how we're going to do this. Not only do we don't work with physicians alone. We work with systems. We work with health institutions. And actually, I work directly with the Ministry of Health, with the health minister, trying to create pilots and show to Indonesia to develop an Indonesian system of care, not an American system of care, but an Indonesian system of care. Leave that aside, we learned something from there. About 6 months ago, we certified our 4 health systems in India, one in Bangalore, one in Hyderabad, one in Navi Mumbai, and one in Kerala, all 4 certified for heart attack and stroke. That's close to 80 to 100 million people that we would impact in terms of heart attack and stroke. And how do we take our systems of care that we have here, really look at quality models across our platform and take it to these countries, teach them, educate them, whether it's access or so, Don, very well, whether it's Northwestern or Boston University or UPMC or in my system, it's not the physician, right? It's when the patient comes in first. What happens before the patient sees a cardiologist or before they come to the cath lab? What happens after they leave the cath lab? And what happens when they go home? How are they followed up? There are more lives saved before and after than what I can do in the cath lab. And how do we bring this level of system of care? And how do we teach people in the rest of the world that that's really the key in terms of what we can do? And that's what we are trying to develop in India or in Indonesia and in the greater Middle East. So we signed with in Abu Dhabi, as you know, Don, with the Ministry of Health there, and across the Emirates. How do we look at systems of care there? How do we look at models of care there? How can we work with not just health systems, Ministry of Health, payment models? The same thing that Ritu was talking about. This is not just a national problem, it's a global problem. And I'm proud of the AHA that they are investing not just here, but all over the world in terms of how do we develop some. And I really believe that we would learn a lot more from them than we think we already know, right? In every one of these countries, which are really low resources, they come up with these models. And maybe those models will teach us more as to how we can do it in, in North America and in high resource countries. Even though Ritu has clearly said, we call ourselves high resource. Are we? It's for a select group of a population that we take care of. And there are large swaths of this country, especially in the middle of the country, where they don't get care. Care is so disorganized or disjointed that really some of us have to learn in some way or form as to how we can develop these things and how way more people can benefit. And I really think and applaud the AHA that we are now in 13 countries and close to, 1 billion people we would impact in the next 5 years in terms of what we can do. And you mentioned quality. So what are we trying to do for people who are non-physicians? What does systems of care mean? Systems of care basically means like when a patient comes to a hospital, we get an EKG within the first 10 minutes. Somebody sees the patient very quickly. That EKG is transmitted to somebody else. If the patient's having a heart attack, do they get an aspirin immediately? What care is provided in the cath lab? And then when they go to when they get discharged, how is the follow-up care? Are we using our 4 standard medications for, after a heart attack or with the heart failure patients? How do we use quadruple therapy? All of these things is what we are talking about. And the advantage now is when we develop systems of care, let's say in 4 health systems in India, just for a minute, now within a year, we would have records that we have in India to look at their own patients, that the data is stored there. Now, with the help of our AHA staff that are sitting in Dallas, we look at their data and we help them manage those patients and say, hey, this is your data. How can you now improve your system of care? Along the way, we learn from them at every level. Okay, this is what's happening there. How can we now use that in a reverse way in North America, whether it's in Pittsburgh or in greater Cincinnati, and how can we learn from there? So, I'm passionate about this, Don, and this is something that, every day I come here and I say, wow, we think we don't have access, guys.
Yeah.
Talk about 250 million people having 5 heart failure cardiologists and 1,900 physicians. Now that's access at a completely different level. But this is great. Thank you so much for the opportunity. Meaning we all have to do this together, whether it's Jeff with innovative ideas or Ritu with with what we can do with payers or systems of care. I think it's a global problem, and I'm proud that we are all together on this, and the AHA is front and center. And I'm Don. That's on to you. So.
Well, DP, your passion is oozing through the camera, as always, and so we really appreciate that. I think you made a really key point, which is true. I think across all the topics we're talking about today, that the evidence base is clear. That is universal, right? The evidence base that's been developed about care, whether it's treatment and secondary prevention, whether it's primary prevention, whether it's primordial prevention. The evidence base is solid. It's there in our guidelines. AHA and many other organizations, help to create those guidelines, even generate the science, that populates those guidelines. But implementation, while the concepts are universal, the implementation is local. And I love the way you kind of you talk about that the solutions, that are really relevant to a local situation, whether that's global or rural or center city in the U.S. Those may be unique, but they may be generalizable too. And we can share those great ideas across platforms and across situations and geographies, and figure out what has to get pieced together locally to make it work in that given environment. So I love the fact that you're talking about this And you mentioned a number of programs of AHA, the Get With the Guidelines program that, really provides the sort of templates and the order sets and the make sure that chain of survival and the system of care is really working soup to nuts, right? Beginning to end. But also these certification programs where we're actually making sure that people are, implementing in the relevant way for their local situation to make sure that the quality is maximized. And so thank you so much for the work you're doing in this area. It's really, again, your passion is really evident. But let me open it up to all three of the panelists and say what haven't we touched on before we turn to folks' questions. But what other things have you heard today that really resonated with you that that you'd like to kind of bring back around and kick the tires on? Very open.
I love the perspective. I love the perspective that DP has just brought to us. We can complain here in the States, but it's a whole other level when you leave and go to other countries, such as what he was discussing in Indonesia and others. It really hits home, and we have those pockets. All of us are witnessing that. I went to school at Northwestern for medical school, and I was working in Cabrini Green at the time as a volunteer. And so I saw that firsthand back in the day. And now that was so many years ago, and we still have this, but at least I feel that the conversation is happening much more now than it was even a decade ago. And so the solutions and our thinking and our approach just coming together is much more cohesive. And so that makes me optimistic that, we're headed in the right direction if we're all in it together.
Exactly.
Yeah, I guess I'd add kind of like the science is pretty well understood at this point of like why we have the issue. I mean, I mentioned before we got on here, like I wore a CGM for over a year and a half. So like we know like what, the life essential rate really is the life essential rate in terms of what's that there. So I don't think there's a lot of debate left there. I think that the parts that are the challenges, and DP, you brought a whole down about the challenge in this is that, and Rita, you mentioned the same thing. It's like, what's the business model, right? What's the business model so that the provider and the care team, because I don't think the doctor should be spending a half hour talking about your behavior and what you're doing in your life, but maybe we could have a nutritionist or a social worker kind of getting into some of those things, because they're probably well trained to do that. And again, getting people to top the practice or license, how do you get someone to sit down there? But where's the business model to afford that? In an Oak Street model, they can put that all together, right? Because they're doing this. But how do we bring that down to a place where they don't even have access to insurance or to a doctor, right? Down on the health pathway. So the business model has to work, as DP said, not just for a select few that have the fortune of being a dual eligible member or having the means to pay for this themselves. We have to get that access. And then, the real thing is how do we support people on the behavior change process? I mean, I tell you, it is not easy. I love chocolate. I love rice. I'm a marathon runner. I've run 44 marathons. So when I found out that those things weren't in my diet, like that wasn't easy to change without knowing what my dad went through, because he lived in the hospital for, I don't know, maybe a fifth of his life. Maybe it seems like he went there a lot. I don't want that. I don't want to live that life, right? That's one way for me to drive behavior change, but not everyone has that. But it also costs a lot of money for my behavior change to eat healthier and to do a lot of things that I do is not really affordable for most people that don't have the financial means. So, I mean, I think those are the things that are real challenges. Like Rita, you mentioned this, how do you do this at scale? Because you could do this amongst a little population and say, hey, I got this proven, but like, okay, that's just unrealistic because you're not going to scale that one. So I think part of this is you have to take all those factors and then flip it over upside down and go over to DP and say, well, now can you do this? You pick, the country, can you do this? Yeah,
Jeff,
there.
you are telling a very valuable point, right? We have to include the patient in this conversation. We have to include the community in this conversation. The community can be just local, the community can be global, the community. So we have to get like you are involved, right? How many more people can we get involved in their own care? somewhere, like
Yeah.
Dawn mentioned, the trust, right? Somewhere along the way, the trust is gone. So whether it's empathy or whether it's putting ourselves in their shoe or bringing other people into that's why it's a lot harder to treat hypertension than coming in last night for me and opening up a circumflex, right? I know people would look at it differently, but I really believe that opening the circumflex was a lot easier than treating 3 hypertension patients to take 4 medications and telling them, a mother or a dad with multiple other issues. That's a lot harder. So how do we teach them? How do we educate them? And how do we bring all of us together is something that's, it's not easy, but I think we are doing certain things, and hopefully you get more people involved in these things other than doctors, right? Things will
Yeah.
work out a lot more better than, whether it's an APP, whether it's a medical assistant, whether it's somebody who they can relate to, you know that's more important. So anyway,
Yeah.
Don, go ahead, please.
No, you're all making such great points, and I don't want to leave behind the importance of advocacy, right? That policies that create the environment where the healthy choice is the default choice, and where the whole environment is tilted towards health, right? Safer streets where people can walk, access, as you were saying, Jeff, to healthy foods, that are actually affordable. All these things are, have to happen at the policy level to make it even possible for someone to try to optimize their cardiovascular health and or avoid their next hospitalization for heart failure and all those things. So, so much going on in this space. I want to make sure we have some time to get to some of the questions. Some of them I think we've already addressed. There was a question about PPG, which I think, Ritu, you actually addressed along the way. Let me turn to some of the more wicked problems, and it's really what we were just talking about. How do we meet people where they are to affect lifestyle modification, to affect behavior change, whether that's medication adherence or whether it is weight loss or more physical activity? What are the levers that we can pull on an individual level with our patients through these systems or leveraging technology? How do we do that more effectively? Anybody can answer.
One of the ways is there's a technology called just-in-time interventions. A lot have been studied in the behavioral space, but in the cardiovascular space, there are some studies. So for example, using GPS, and before a person is just about to walk into McDonald's for that Big Mac, they'll get a text saying, Ritu, don't do it. You don't need this Big Mac, or, so just in time. So I motivate.
Maybe a light taser. Yeah.
Like turn around and, don't go there. So, some of those technologies are being used, and they can work. University of Michigan is a big proponent, and they've done a lot of work in that space. And so that's one thing. The other is this idea of, social media gets a horrible rap. It's like, Twitter or X is the angry emoji, but other platforms can actually bring people together. So for example, you could have communities that are, exercising together, and they're all posting, and there are some changes that can be, fed off. They can feed off of each other and improve outcomes. That sometimes is even more than if you're giving monetary incentives, for example, may not work as well. And I think this idea fundamentally is of community. Historically, like, for example, in the South, if someone didn't know where you were from, didn't know your story, they were never going to trust you. And so this sort of view is now become universal. Like, if I don't have context, then what am I going to believe what you're saying to me? And that's certainly even with the doctors. Like, you have to have context so the patient actually believes what you're saying and may feel that you care enough that they'd want to change. So
maybe to extend this conversation, I see one of the comments here about building a new platform that was going to leverage gamification to improve physical activity. And I want to give a shout out to these kinds of approaches that leverage the technology, but also leverage behavioral economics, right? Like aligning the incentives so that people want to do what we need them to do for their health, right? And it's not as simple as in 6 months we'll lower your premium. That's just not a very good motivator, right? There's a lot of wonderful science here about the kinds of things that do motivate people. And gamification, love that our questioner is going to use that. Gamification is a great strategy. Making team-based approaches in that gamification where other people are cheering you on, if you will, can be useful. Some really wonderful work about things like lotteries, right? People would much rather have a small chance at a big prize than, a guaranteed prize 6 months from now. So thinking about things like lotteries to align incentives with the behavior that we're seeking to promote. Even some really interesting things like not only leveraging benefit through lotteries, but leveraging regret, right? There's this thing called the Dutch lottery that my friend Kevin Volp has used in some of his research, where in Holland, you buy a ticket for the lottery, but you don't win individually, your zip code wins. So if you didn't buy a ticket that week and your zip code wins, your neighbor is getting the money that you could have shared in, right? So leveraging that regret piece can also kind of help people kind of move to the activities and behaviors that we want them to as well. So, would definitely encourage people to think about using the technology and enhancing it with some of these behavioral economic strategies, because they really can be quite effective at things like smoking cessation, weight loss, a number of different demonstration projects that I think have done that. Maybe just in the last couple of minutes, quickly finishing up, there are a number of comments about AI, agentic solutions, machine learning. We have to get there through the technology, but then what happens to it? How can we leverage more of these AI and agentic solutions to, again, extend the provider and also, get to the patient? So any experience with any of those things that you all have?
Certainly. Oh, go ahead.
Go ahead, Ritu, please go ahead.
No, go ahead. I give you a chance.
No, it's you, please.
Oh, okay, well, I mean, we're done some work with the AI in imaging, as I am a cardiovascular imager, and clearly one of the problems is that everyone thinks that bigger is better. So big data and large language models, and it's going to solve everything. Well, we actually did a study where we looked at large language models such as ChatGPT versus a small machine learning model that we use for echo reports, and trying to harmonize them across institutions across the country. We found that actually our small echo map model was much more efficient and more precise than even the ChatGPT, this large language model. So I think there are fine-tuning and sort of ideologic changes that must be communicated to the larger community and people who are doing this work, that you have to think beyond just what question are you trying to answer when you're trying to create an algorithm. And in the imaging space, that's a key part. So being efficient. Yeah.
Exactly. And Jeff, maybe we're right at the end of time, but maybe I'll give you last word on how AI is being used in your space.
Yeah, a big part of it is listen to what the consumer patient member is saying, what they want. Don't prioritize what smoking is the most important thing to do. Well, they don't want to do that. So how do we listen to what they're doing and then use AI to get the right content based on what they're telling us, instead of just saying, well, smoking would be the best thing. They might not be ready for that. So how do we listen to that and use AI to take that and interpret that into the right content that we have, using a lot of the AHA content around that to deliver that in a personalized way to the individual? Before, that would all be like hard coded. Now this is all AI enabled in the process.
Yeah, it's really AI's version of motivational interviewing, right? Is again meeting the patient where they are. What's the change that they're able to make that they can see progress on, not what we're going to dictate to them in a sort of paternalistic fashion. So, well, gosh, what an amazing discussion. I'm so grateful to all three of you for being here today, for giving us really just a glimpse, tip of the iceberg, of where this field is going, how we can improve access, innovation, and prevention, and take better care of our patients leveraging technology, but also keeping that human touch, as a very important part of this. So I want to thank our panelists again. I want to tell all of you that we are excited to be in New Orleans this coming weekend, as was mentioned, for American Heart Association Super Bowl. That is our scientific sessions, November 7 through 10 in New Orleans this year. A lot of exciting science going to be presented around these very topics, innovation, technology, over 188 abstracts in the health tech category. So certainly going to be checking those out. But please stay tuned to these AHA and health webinars. I think they're a very exciting platform for us to have dialogue like this and to engage more and more people in solving these wicked problems. So again, thank you to our panelists. Thank you to all of you for attending today. My name's Don Lloyd-Jones again, and we're going to sign off here, but look forward to seeing you again in the future.
Thank you to the American Heart Association and to everyone that joined us today. Please visit our website, HLTH.com, to catch up on all health webinars and watch the recording of today's session. Apply to join our New York Insider hosted in partnership with Team 8 on December 10th.